The topic, we've already heard a lot, but have we really come to crystallize as to what we should be doing? And that is why this session is, and I hope at the end of that I can give you some, after hearing from the panel, a summary to take home the message. So alignment conundrum, is it even worth a debate? Well, I think it is, because that's the most hot topic today. And there are so many names that are thrown around. Let's try and crystallize on what it means. So we have mechanical alignment, we have kinematic alignment, and the variations of kinematic alignment. We have adjusted mechanical alignment, functional alignment, and so let's get going. There are two other things that we need to understand while we understand alignment. One is constitutional alignment of human beings, and this CPEC classification, which has really come to forefront at the moment of all the discussions. We know that mechanical alignment is a gold standard technique for ever since total knee is going on, and it's a concept of equal load sharing by medial and lateral compartments. Mechanical axis is aimed at zero, rectangular flexion and extension gaps, but in order to achieve that, we would need sequential releases, depending on the deformity. But the long-term data shows that after having done that, the survival is excellent, and there is no other technique that has reached that endpoint. Some of the data that Anup mentioned is from a Caucasian population with a very low deformity to begin with. So I don't think we have the data for the severe deformity that we're talking about. With that introduction, let's get going. Here are the three patients with increasing grades of Calagrin OA, and I would like panel to answer to me what is their mechanical alignment philosophy on this. We start from that side, Vaibhav.
So these days, as I said, the reason why we are still debating alignment is, and we encroach, the other sessions we are encroaching on, is the fact that alignment should not be looked in isolation. I think alignment and balance are conjoined twins, and the reason we are still debating on alignment, and we have got such an expert panel, is because we don't think balance. So for any of these cases, for me, the screen, I do most of my cases, or in fact almost all cases.
No, that is given. Alignment and balance both are important. Here, so, what alignment would you
so
I will,
I will let my balance decide my alignment here. Okay, so for me, ability to create medial pivot joint without using a medial pivot poly is the key. For that, I am ready to deviate something on my mechanical alignment. And if my alignment says, if my balance says that if I have to put my component in 2 to 3 degrees of varus without deviating far away from mechanical alignment, I will do that. So my balance will take priority over the alignment.
So exactly. So now looking at these three different variations, what do you think you're going to start off with? Each of them, and what is it your endpoint going to be?
So again, as I said, balance will be the key. I will not deviate, I will not dial in more than 3 degrees of varus or valgus in any component, and not overall deviation of 5 degrees of HK angle deviation. But this sagittal alignment is much more important for me in these cases, and that's what I'll look for.
Okay.
He's making sense.
Tejas.
I think it's almost the same, because my balance is going to dictate what I'm going to do. For the first knee, because we have an example here, maybe after removing the osteophytes, I could just go with the mechanical alignment. I don't need to dial in a varus also. So maybe with the increasing severity of the varus, and depending on the ligament tension, the ligament balancing, I will dial some varus into the tibia, but again in a restricted zone in the functional philosophy, not more than 3 degrees varus or valgus.
All right, so I think, can I just go back to this slide, and can you tell me that, because what you're saying probably is not clear to understand how you're going to achieve it. Do you start off as, are you a mechanical alignment, kinematic alignment, or adjusted mechanical or functional? Give me one of those 4 answers.
So 85% of my cases will be mechanically aligned, 10% will be kinematically aligned, and 5% will be anatomically aligned.
Thank you. 80% mechanically. Then
functional alignment.
Harshan.
So we are doing restricted kinematic for all varus knees and mechanical alignment for our valgus knees.
Mechanical for all valgus and functional for...
And restricted kinematic, or you can call functional.
Okay.
So
Parag?
definitely mechanical axis, at the most adjusted mechanical.
All right, Thorsten?
I agree completely. I'm doing mostly adjusted, basically mechanical alignment, but it ends up was an adjusted mechanical alignment.
Ashok?
Adjusted mechanical, you just missed out. Can you go back to that earlier slide? Yeah. You missed out the 16 other variations of kinematic.
No, I think I didn't write them because they are all the variations of this.
No, there's no space for it on the slide either.
Yeah, I think, and all of them can be categorized into that same, Amar?
Yeah, just the mechanical. But I agree. I mean, I think I'd like to lay this alignment discussion to bed because it has nothing to do with alignment. It has to do with stability, right? We can't choose the alignment, but we can all choose what a stable knee is, right? So
I think you are absolutely right. It's why would you think that the people who would align along any of this aspect is not going to balance as well? So I think it is given for any total knee that you are going to balance the knee. Anyone who wants to use any of this alignment is also going to balance, sir. But while you're doing balancing the knee, which is the alignment that you select, that's the idea today.
Rajesh, just to extend the point that Amar mentioned and we are discussing, at one time constitutional alignment was the buzzword. Everybody was talking about Johan Belleman's work, right? Today almost nobody talks about it.
Exactly.
And I mean, you've very kindly put 4 variants here. I think there are 17 of them if you include the CPAC as well. And I think to Amar's point, it is stability, balance, and soft tissue envelopes that actually dictate outcomes. You can put that into any bucket you want, whatever philosophies you believe in, but if you don't have stability and you don't restore your joint line, whether you want to keep it horizontal or oblique, I think you're missing the point.
I think you are absolutely right. And I think you can only have number of variations to a technique if that first technique is not either solid or very clear. Then you're going to have more variations. But let me tell you this.
Let me tell you what I certainly believe. I can examine a knee and I can see that knee is stable, varus valgus, and in the sagittal plane. And I almost don't care what the x-ray looks like. You can give me an x-ray and say that x-ray looks perfect. And I can examine the knee and be like, no, it's not. So it's the stability of the knee that's more important than the x-ray.
I think my take on this is that the whole question of this other alignments have come up is because if you do a mechanical alignment, which you saw most of the people on the panel do a mechanical or at least start off with a mechanical alignment, is that you would need to do higher amount of soft tissue release. And kinematic alignment, what it has taught us is that you can do away without soft tissue releases, provided you are ready to ignore some amount of the alignment. And I think that is the crux of the whole thing.
But why are we so afraid to do soft tissue release? We're surgeons. That's what we're supposed to do, right? We're supposed to cut things. And you can cut the soft tissues, or you can cut the bone, or you can do a combination of the two to get where you need to go.
Yeah, I think absolutely. If you're going to use a mechanical axis alignment as your alignment philosophy, you will need to do soft tissue releases, and you should not do away without doing them, because that can still lead to failure, although your alignment is correct.
We agree, and I think that's what it is. So we were told that the TKR is a soft tissue surgery by some legends, and then it was the bony surgery. I think it's a mix of both.
It's a mix of both.
Striking the right balance.
Can I add a very quick, very small point?
Yes,
So we do, especially to Dr. Ranawat, we do all our knees using navigation orthopilot for the past 17 years. And the system gives you an LDFA. You often find when the system gives you 4 or 5 degree valgus LDFA and you correct it to 0, you end up with the asymmetry of the cuts. And your whole soft tissue balance goes for a toss. Life becomes so simpler if you just undercorrect that LDFA to 2 or 3 degree valgus, and you end up with a more stable joint without the need for any soft.
Absolutely, we are coming to that kinematic alignment, the philosophy of that, what you are alluding to. So the pitfalls of the mechanical axis alignment, I think, are the need for ligament release. And the second is that constitutional alignment is not always 0 degrees. That's another factor. And can all these 2 points be related to the dissatisfaction, which is what we are trying to chase? And I think that is why the kinematic alignment came into vogue, because it is a true femoral resurfacing. It is challenging the gold standard technique currently because it is a pure bony procedure without no ligament releases, calipered measured. But the problem here is that your alignment can be completely haywire, 10° of varus. So does anyone in the panel do here a complete kinematic alignment without disregarding the overall mechanical axis alignment? Amar, you don't. Ashok, you don't do kinematic. Yes, Thorsten?
What short comment regarding the ligament releases? So I do mechanical alignment since almost 30 years, or let's say adjusted mechanical. In all these cases, in all my cases, after removing all the osteophytes or respect all the anatomy, I do in less than 1% of all my cases a ligament release if I do mechanical alignment, in less than 1%. If you follow all the principles of total joint arthroplasty or knee arthroplasty. So I never understood the argument kinematic alignment is great because you don't have to release anything.
Partly that may be because you have not so many deformed cases as us. Let me just
Probably
ask a different
yes.
question.
Just
One
as
minute.
easy
One
case.
minute. Mechanical axis alignment. What percentage of cases do you end up with releases? Amar, we're talking about varus knee. If you are doing mechanical axis alignment, what percentage of your cases you think you will need to do a formal release that we're talking about of the superficial MCL?
I mean, you do, just to get your exposure, you release the deep MCL, right? And then you come around the corner, do that. I mean, it's just part of the exposure if you're doing a varus knee.
The deep MCL is taken, the posterior corner. I'm talking about formal superficial MCL.
No, that was like an ancient technique. If you're talking about the periosteum.
Ashok, do you ever need to do that?
Again, Rajesh, the issue here is, I think we're mixing up issues.
No. You tell me answer to this. Do you ever do a periosteal release at all or no?
Of the superficial, never.
Never. Parag?
Yeah, so deformity, varus deformity, to answer your question specifically, more than 20 degrees, 100% of the times I will require some kind of release.
Well, Harsimran?
Whenever we correct LDFA more than 4 or 5 degree, we have to end up with a soft
What
tissue
percentage of patients today are you doing the superficial MCL release?
No, hardly anyone. No person.
I think the whole alignment thing should be seen with the deformity also.
Yes,
Like
so we're talking about severe deformity
if
at
you're
the
talking
moment.
about severe deformity, I don't
Right.
think the alignment thing plays such a big role. And the kind of deformities we see
Do
here,
you do subperiosteal release with the?
in rare beyond 20-25 varus, otherwise.
I do it in
rare.
30% of my patients at the moment. May not be, but a titrated one, maybe partially, but severe deformities almost every time.
No longer needed. No longer needed.
All right.
Rajesh, can I make a point? People who advocate are ardent admirers of this kinematic technique. When you see the actual procedure being done, they are subluxating the tibia in front of the femur. Can somebody explain to me, how do you achieve that translation of the tibia in front of the femur without soft tissue releases?
No, you can bring the tibia forward by doing the deep MCL release and go to the posterior corner.
So deep MCL is not soft tissues?
So no, we are not talking about that.
What are we talking about here? Let's get real. Deep MCL is part of the soft tissue complex. If you say
Ashok,
you do not release the superficial, point taken.
That's it.
Okay.
I think the kinematic alignment is talking about the superficial. So I think if I do pure mechanical axis alignment, I would think I needed about 25 to 30% of the patients where I needed to release the superficial MCL, maybe titrated. But I have also moved on to functional and that need has gone down. So there is a need to understand what is going on between the two. So let me just ask so there is no one who's doing true kinematic and going up to, I think Anup does true kinematic as he says, but he does have some amount of limit to the amount of varus you will accept. We'll come to that in a question. So today, true kinematic here in Mumbai for the crowd, nobody does that true kinematic where you go even 10-degree varus on tibia.
So what he's referring is to the unrestricted kinematic. Nobody does it.
Nobody does that. but it does, and the question is to restore the constitutional coronal alignment to its pre-arthritic state. And we'll come to that in a minute. I don't have anyone who does kinematic alignment. I'd kept these two cases for them. You have two such cases. Are you going to do a true kinematic alignment here at all? Or I think everybody would agree that everyone would want to do a little bit of adjustment to their mechanical axis alignment to reduce the soft tissue releases.
Also, valgus knee is considered an inferior pathoanatomy, so I don't think even the strong proponents of kinematic alignment would be comfortable doing it in a
Havel's original cases, 55% were valgus knees. But look, if you look at that, the severity of the valgus, hardly any.
You know, well, a lot of times in the valgus knee, the problem is not a soft tissue issue; it's a bony, defect, and the lateral femoral condyle falls into a defect in the tibia. So once you restore that, the leg becomes aligned and stable.
Yeah.
You know, and what I haven't heard about is like doing a reduction osteotomy. So not only will I do a soft tissue release, I'll do a bony release. You know, so not just removing osteophytes, like literally removing, the medial side of the tibia. So, and we've all heard about doing, medial epicondylar procedures to really get balance and distalize it, right? So there's lots of things you have to do for severely deformed knees.
I think the absolute point that before you touch your superficial MCL, there are so many things that you can do, apart from removing the osteophytes, the flare of the tibia, reduction osteotomy. Occasionally you can downsize the tibia, not a very common thing, but you can do that. You can also actually remove the posterior osteophytes on the femur, but having done all of that, some of the severe cases, you might still need to do something more.
So in this case, such a severe valgus, the MCL is probably going to be incompetent. We've got to use a hinge. And when you use a hinge, when you use the stems on either sides, then you're probably not going to think of kinematic alignment at all, because the rods will dictate what alignment you have, that is mechanical, unless you keep it up on one side and put extra cement or wedges.
So whenever you use stems, it's the stem, unless it is a short cemented stem, it is the stem that is going to dictate. That's for the revision surgery. Here, I think actually you'll be surprised for I was going to do for the valgus knee, I had kept everything constrained and the hinge ready.
It just needs a PS knee.
Yeah, well, and a lateral epicondylar osteotomy may be required, but I was happy that I could balance it without, but by adjusting my alignment, my tibial cut, the femur, I've kept it 2 degrees of valgus, tibia is also in valgus, so overall about 3 degrees of valgus, but I could get this done without having to put any osteotomy or a hinge. So on the varus side again, both the components in slight varus, and that to reduce the extent or the need for the soft tissue release. Now, pitfalls of the kinematic alignment, it's a vague concept. There is no clear definition. Every user has a slightly modified way of doing it, and that's why there are 15 or 16 types, which Ashok was trying to mention. There is a lack of patient-specific implants, which you would need if you're going to be in a gross amount of varus or valgus. And to me, the question is, how do you judge the individual pre-arthritic constitutional varus? We all know that there is a varus in a lot of the population, but do you have any way of judging it? I think, Harsimran, you use kinematic, and you might tell me.
So we use OrthoPilot navigation for most of our cases, and the system tells you an LDFA. Like in this case, the LDFA would be between 2 and 3 degree valgus. So
no, my question is that you have an arthritic patient who has come to you, right? What was his pre-arthritic constitutional varus? How would you?
So there are ways to do that. One is intraop, one is on the X-rays itself. So if you intraoperatively, if you account for 2 mm of cartilage thickness over the most eroded portion, where it's bone on bone, and we do it by using technology. So the moment you correct for it, the system will tell you at what angle is your lateral distal femoral.
Yeah, Vaibhav?
The problem
No, I
with
always-
this is, I agree with Rajesh's question, in severe deformities, what we see, to find out the pre-arthritic constitutional varus is very difficult. So I think it's best to aim for mechanical in this, which has stood the test of the time, but Anup might bring it up in his talk. You try and create the joint-like obliquity to a certain extent in these cases, and you can be guided by that. And I've had this discussion with Anup, and I'm sure he'll speak about it. But it's to answer your question, Rajesh, it's very difficult.
It is difficult, but Harsimran has a point, and one of the technique is that you find out the tide mark. They call it tide mark, where the cartilage is still intact and you have a bony deformity, and that is the point where it is. But I think there is some amount of remodeling that occurs in the area. And also you're guessing the amount of cartilage. So I think it really is very difficult. Yes, Vaibhav?
No, I always struggle with this find, whether arthritis caused varus or the varus caused arthritis. I think it's a fundamental question, because is arthritis a purely mechanical problem or is it a biological problem? Because if it's a biological problem, it is the arthritis that is causing the varus. And in that case, your philosophy should be different. If it's a varus causing arthritis, I think that's what you call as constitutional varus. So I think that's a fundamental question as a society we should know.
Exactly. I think that excellent point. That's what I wanted to really mention, that if the constitutional varus of the patient has led to the arthritis, do you really want to go back to that sort of an alignment? And if that was not the case, then why would we have so many youngsters or the sports medicine people doing HDOs to correct the varus that people have, constitutional varus? Why should we really be looking at? Excellent point, Vaibhav. But so the reports have shown that 30% of the people have outside 3 degree of constitutional varus. But that's not all. We've had a lot of people who have tried to look at the phenotypes. McDessie is not the only one. Prior to them, a lot of people have given different phenotypes for the human. And the Hirschman gave actually 125 types of phenotypes that is possible. That's crazy to understand. But McDessie's is the most recent one and the one which has caught the attention of the mass, and therefore I think we should discuss it for a minute. We've already had a discussion about the LDFA, so I'll pass that, the types that we have, but the basic premises on which they say that it is important is that for the various types, they had better success with the kinematic alignment without doing the releases. These are the kinematic alignment successes, and the lower down without the soft tissue, with mechanical alignment, very little success. So that you needed a soft tissue releases if you did mechanical with all of them. And that is the premise. But I think, to me, fundamentally, the paper has a flaw because they used a normal population from another country, Europe, and an arthritic population from the Australia. And I don't think how we can really relate that. I tried to use the CPAC.
All right, can I go back for one? Because I see this all the time. We all know the apex proximal row is just to make it 9 boxes, because there's nobody that's in that position, right? Or it's like 0.1%.
Yes.
So why is it even on there? It shouldn't even be on there.
So very rarely you do have people in that, but very, very rare.
Yeah.
And I think the differences are this joint line obliquity also are so little.
It doesn't add to the classification. Anyway, so.
And also I think that there is a movement between this particular type of classification, because we've seen that in India itself, Guruva's study, that 20% non-arthritic population is in Apex 1. But 53% of the arthritic patients are in Apex 1. And Bagaria's study also, I think I've put the slides here, that the distribution is different. So, does anyone use this classification to make
If anyone ever quizzes anybody on an exam about the apex proximal, I'd be furious. You don't need to learn something that doesn't exist.
Exactly. So, but the question is, do you use Vaibhav in your practice?
With all the apologies to McDessie and Belleman, I think it has only compounded our problem. All the action, the premise of the CPAC classification is the justification for kinematic alignment. And I think all the action is happening in sagittal plane. You are doing the same mistake of observing things statically.
In one plane.
And in one plane.
So
I think
Tejas?
it's a flaw.
No, because
Anyone here?
No.
The joint line obliquity is only we can come to know by this classification. You may not use it in its entirety, but joint line obliquity actually has a great role in balancing the knee. This is what over the years we have seen.
Yeah, again, I have a slide, but I have hidden it just now. There are 5 ways of measuring the joint line obliquity, and sports medicine people measure it differently, we do.
So honestly speaking, never use it, and our numbers are only going up every year of the knees we do. My whole team is here, but we've never used it, so probably we are doing something right.
Thornston?
The same, I never use it at all, and we have to consider that we are just looking always for the coronal level, and we don't, the sagittal plane is not used at all here. And probably the sagittal plane plays a major role. I don't know exactly, but we can measure it. So it's just a part what we are looking for. So to answer your question, I never use, or we all never use it in my institution.
So I started using it for all my patients. For a year I did, and I realized that it is making no difference in the amount of releases that I had to do. And I still measure it and look at it, but what has made a difference is moving on to the functional alignment, and I'll probably come to that. So I did it for a year and made my cuts accordingly because I use navigation or robotics, but it didn't make too much of a difference in how my soft tissue releases occurred. And as I mentioned that from different part of this is a study from India as well. Guru was saying that if you see the overall alignment severity in different McDaisie's paper was hardly any out of alignment, and this is the severity here. And this is Webber's paper that it's upside down classification here. The percentage here is much different compared to the percentage.
So I'll just make a point that you were asking, that why is there no thing on this side? So it changes when it becomes arthritic, and this is the data from arthritis. And I think that the only advantage of CPAC for me is to rule out the patients on whom I'll not do a uni. So ironically, if someone has got a varus deformity and the joint line is pointing up, we should not do uni. That's the only advantage.
We'll talk that later. Don't confuse us anymore on that.
I know that CPAC
so here we are trying to reach a conclusion on what we do for a total knee. And this is the paper from Rajesh Malhotra. Again, there are many other important factors that we need to look at in an Indian population. Hip knee anatomical axis variation from 3 to 27, femoral bowing, 9 degrees on either side, tibial bowing, something unheard of in the Caucasians, 6 to 18 degrees condylar plate angle, again huge. And this one I alluded earlier that non-arthritic 21% in apex CPEC 1, 58 in arthritic patient. There is a movement. There is a movement. This phenotype that is described probably is not uniform. And in the Japan, again the same, which is like an Asian population, severe arthritic CPEC 1 is 53%. Okay, now what is this? We have few more minutes. Let us understand what is this adjusted mechanical alignment. It is a transition zone between mechanical and kinematic to try and reduce the femoral, the soft tissue releases. Where your tibial cut, you still keep at 90, and femur, you make your adjustment. Is that right, panel? That you make your adjustment on the femoral side to try and reduce? Yeah, Thornston, you wanted to say something.
Yeah, that's exactly. That's what I mainly do.
Yeah, and do you have a boundary for this? How much you would go? Adjustment on the...
Yes, usually not more than 3 degrees, so it's...
And does everybody agree to that, 3 degrees or, yeah, Tejas?
3 degrees.
And Dr. Harsimran, you think?
Yes, so
3 degrees. So I think, so this is what I started doing almost 10 years back for a different reason. We were discussing with Amar that very fat people, you keep them in 0 degree mechanical axis, their thighs rub and they would not like it. So I started keeping them in 2 degrees of varus by making adjustment on the femur. So for many years I did that. And here is one such example, very severe, and 10 years, actually 16 years now, it still remains functional and well. But now that actually did not change my soft tissue release rate. What did change is moving on to the functional alignment. And the change is this, that I started keeping that 1 or 2 degrees on the tibial side, rather than on the femoral side, and still remaining within 3 degrees of the mechanical axis alignment. So does anyone follow this functional? Yeah, Harsimran.
So this is what I was alluding to when I was saying earlier. The system will tell you how much of your angles are. You need to just undercorrect them. So we are retaining the natural phenotype of of that particular patient, but we are not correcting it all till the mechanical axis. We are falling short of it.
So, yeah, I think I started off doing that according to the classification, put the initial cut as to what, but that did not make a difference in my soft tissue. But when I started cutting, I showed you those earlier cases. If minor varus, I would leave them in 0. If it was a severe, which was not correctable, I'll start with 1 degree of varus cut tibia. I've gone up to 2 degrees. I've still not gone more than that on the tibial side. But that has reduced the amount of soft tissue releases that I've been doing to a significant. In fact, I presented at the Knee Society in London and is going to be published in the Knee Society proceedings hopefully soon in JOA.
I still don't understand what is wrong with, a soft tissue release, the semimembranosus. What's wrong with that? Why is that such a thing we should avoid?
I think semimembranosus or the posterior corner, people are not worried. It's the touching the MCL. We want to try and balance a knee without having to do the severe releases on the medial side, because there may be an occasional time that you over-release and you're now lax. And these are the people who might find it difficult going up and down the steps or do the tasks. That's why. That's the whole idea.
Rajesh, but
yes.
Very, very few times do you release the superficial middle collateral. When you talk about soft tissue releases, it's the exact thing that the posterior middle corner, the semimembranosus, reduction osteotomy. And to Amar's point, by the time you've done the reduction osteotomy, you've decompressed that enough, even in severe deformities, to be able to achieve your correction. Superficial is a diabolical step. I agree with that.
Sir, when we do soft tissue releases, we do balance in 0 degree extension and 90 degree flexion, but then there is some imbalance left throughout the arc of motion. However, with modification of bone cuts, according to restricted kinematic technique, when we don't release the soft tissues, the knee just feels much more balanced throughout the arc of motion.
Well, yeah, I think that is the whole idea, and I think that's why I think we need to move on, and I must give you a take-home message that the alignment conundrum, of course, it is worth a debate, and what we have to take home from here is that the mechanical alignment, which is the gold standard alignment, 0, but it would need ligament releases. So you must learn ligament releases and not leave the knee imbalanced. Kinematic alignment has taught us that you can do away without formal soft tissue releases to a great extent if you do not look at the alignment in toto. However, a lot of people have moved away from there, or there have been variations which have accepted it, where the alignment can be few degrees here with your boundaries. Some people will have a boundary of 2 or 3 degrees. There are people up to 5 degrees. Anup will tell us his boundaries. But what it will enable you is to do less releases for your ligament balance. But the key is that you must have some amount of alignment in your mind and the balance of the knee in your mind. That's the take-home message. Let's move forward. And please join me to thank the panel.